Good afternoon, everyone. This is Eric Miner, and I welcome you to the Vascular Assessment Protocol webinar, the first webinar in the Biomedix Academy series. Happy Monday. There's a lot to cover today. We'll be discussing the basics on two diseases, PAD and CVI, discuss how to identify those patients, and then we'll go over our new vascular assessment protocol, as well as evaluation and management codes for billing purposes. For those of you who are attending via Zoom webinar, please click the raise my hand button if you have any questions. I'll address questions from the Zoom webinar as I see them. I will also address questions at the end of the webinar, so I'll alert everyone when that's coming up, so you'll have the opportunity to ask me any questions that I haven't covered by that point. For those of you who are attending our Facebook Live event, welcome. If you have any questions, I look forward to you giving us a contact, either by giving us a call at 888-889-8997 or by sending us an email with questions to support@biomedix.com. Just touching on our agenda for today, again, we'll be discussing the diseases PAD, peripheral artery disease, and CVI, chronic venous insufficiency, discuss the screening protocol, and go over evaluation and management codes for billing purposes. Jumping right into the disease itself, peripheral artery disease is a progressive circulatory condition that's characterized by clogged or narrowed arteries to the extremities, which can cause poor circulation to the arms, the legs, the brain, or the kidneys. It occurs most commonly in the lower extremities, the legs, the ankles, and the feet, and that's going to be the focus, that's both the focus of the PADnet device and the focus of our webinar today. Because of those clogged or narrowed arteries that we discussed, that decreases blood flow to the feet and the ankles, and it also increases your risk for heart attack or stroke. PAD is a very prevalent condition that affects between 8 and 12 million Americans. However, the incidence rate isn't evenly spread over the population. If you think about 8 to 12 million Americans in the context of 330 million Americans or so, about 3 or 4% have PAD. However, if you look at specific groups like smokers over the age of 50, diabetics over the age of 50, or all patients over the age of 70, you suddenly start finding a lot more patients. About a third of patients in each of those three categories, over 50 with a history of smoking, over 50 with a history of diabetes, or over the age of 70, suffer from PAD. You might have seen on the last slide that it has an over 30% 5-year mortality rate. The actual number is 32%. This slide puts it in the context of other common cancers. For example, you'll see that PAD has a higher 5-year mortality rate than common cancers like prostate cancer, breast cancer, and Hodgkin's disease. And it has approximately the same mortality rate as colorectal cancer. So in addition to being a very common or a very prevalent condition, it's also a very deadly disease as well, which is one of the reasons that identifying this disease as early as possible is so critical. Without treatment, PAD can lead to claudication. Intermittent claudication or just claudication is probably the most common symptom of PAD. That's pain while walking. You can imagine if there's not enough blood flow to the muscles in the legs, as you walk, those muscles start to cramp and burn or become tired because of that lack of oxygenated blood flow. As the disease continues, that can turn into resting leg pain, which is to say pain in the leg even when you're not walking, non-healing ulcers or gangrene. As the disease worsens, the body's far from having, not just having the problem that you can't feed oxygenated blood to the muscles during exercise, but that there's not enough blood to sustain or repair legs if there's damage. So even a small scratch or a bump can turn into gangrene or a non-healing ulcer in these patients. As the disease worsens, there's becomes so little blood flow that the leg can't even sustain or support itself, which is a condition called critical limb ischemia or CLI, which often results in amputation of the leg, one of the things that we're trying to prevent. Other symptoms of PAD include cold legs and feet, poor hair and nail growth. One of my trainer had a favorite saying, "Hair don't flow where blood don't grow." excuse me, hair don't grow while blood don't flow. As you can imagine, as the body loses its ability to heal or reconstruct itself, you start seeing unusual hair growth pattern or simply a lack of hair on the lower extremities. In addition, you'll see erectile dysfunction, again, lack of blood flow to the lower extremities, and an increased risk for heart attack and stroke. Risk factors for PAD include all patients 70 or older. This is an age-dependent illness, and as patients get older, they're more likely to develop PAD. You're also likely, other risk factors include over 50 with a history of diabetes, high blood pressure, high cholesterol, or smoking. Other risk factors include patients who experience foot or toe pain that disturbs their sleep, patients with pale or discolored feet and toes. I mean, you can imagine that the feet are probably not going to be rosy and flushed in a situation where there's not a lot of blood flow to those extremities. So you see patients who have pale, clammy, whitish or bluish feet and toes. Skin wounds and ulcers. We've discussed, as the body loses its ability to heal itself, those become more likely, and those ulcers can be very slow to heal as well. A diminished or an absence pedal or foot pulse, and people who have infection of the legs or feet that may be gangrenous are probably also not a surprise. I did want to spend a second to talk about patients who have suffered a severe injury to the legs or feet. Most of the time in this webinar, we're assuming that this is a systemic process. This is the develop of that clogging or the narrowing of the arteries is occurring over the patient's whole body. However, you can have arterial occlusion that occurs because of damage to the artery, not necessarily something systemic, but some trauma that was done there. That's not going to be the focus because it's such a that's not the focus of today's webinar, because that's not, in terms of percentages, that's not the highest reason for PAD. We're definitely tackling the bulk of the cases, talking about that, sort of that full body situation. But it is something to keep in mind that you may have patients with PAD because of damage to the artery rather than, again, that sort of systemic process. At this point, we're going to start talking about chronic venous insufficiency, or CVI. Your body has a bit of a tricky situation getting blood up from the feet in the veins. As you can imagine, pumping blood 3 or 4 feet straight up against the force of gravity, getting that blood from your feet back to the heart is a challenge that your body has to deal with. Your body's solution to this problem, though, is pretty clever. It seated the veins of the leg deeply within those muscles. So as the muscles in your legs contract, they squeeze the veins that are seated inside, just like a tube of toothpaste, and sort of squeeze that blood up against the force of gravity. Now, as the muscles relax, the blood would generally flow back down your leg with the force of gravity. However, the blood is prevented from doing so by a series of valves in the legs. In patients with venous insufficiency, and we'll talk about this a little more on the next slide, those valves are damaged and they don't prevent blood from flowing back down the leg. That's called reflux, and that's chronic venous insufficiency. Chronic venous insufficiency is a progressive disease that's caused by damaged valves in the veins. It can lead to more serious conditions if it's left untreated. For example, venous stasis ulcers are also very common around the legs and the feet in patients with CVI, and they often require prolonged therapy lasting more than a year to treat effectively. The other facet of chronic venous insufficiency I wanted to mention here is as the blood in your feet and legs tries to make its way back up against the force of gravity, when it continuously fails to use those damaged veins to go back up the leg, they oftentimes use smaller, more peripheral veins to make their way up the leg, which is the cause of varicose veins. Therefore, you'll see a lot of linkage today in our webinar between chronic venous insufficiency on one hand and varicose veins in the other. Just like PAD, CVI is a very prevalent condition. This disease affects approximately 30 million Americans, about 1 in 10. However, only a small fraction of those patients ever seek treatment. There are a variety of misconceptions about CVI, which prevent patients from seeking treatment. So only about 2 million of the 30 million Americans are ever going to seek treatment for their CVI. Without treatment, those with the disease may experience progressive symptoms that can affect their quality of life. And in fact, more people lose work time over venous disorders than from artery disorders. Just another way of looking at the data to show that this is a very common, very prevalent illness. About 40% of American women are affected by serious leg vein problems before the age of 50. Without treatment, CVI can lead to leg pain, fatigue and heaviness, pigmentation changes. We spoke a little bit about the fact that PAD patients, because they have a lack of blood in the legs and feet, often there's a pale discoloration or a bluish discoloration. For CVI patients, there's almost the opposite problem. There's blood that's being sent to the legs by the arteries, but it's not being evacuated out properly, which can often cause swelling, a sort of sort of resting or pooling in the legs. So you'll sometimes find patients who have CVI who have legs and feet that are reddish, brownish, or almost purplish, sort of bruise colored in some cases. Swelling, cellulitis, and phlebitis all go hand in hand with that blood pooling in the legs and feet. So those indications probably won't be a surprise. Ulcers, we've already discussed. The difficulty is similar to arterial ulcers in that there's not a lot of oxygenated blood making their way to the legs and feet, which can cause those ulcers to develop. However, in this case, this is caused by the fact that there's blood pooling, there's deoxygenated blood sort of pooling in the legs and feet, which prevents oxygenated blood from reaching the skin, reaching those areas, which can cause those venous stasis ulcers. As blood pools in the legs, it has, of course, a tendency to clot, which can cause embolism as well. That's one of the most severe side effects or severe symptoms of CVI. Embolisms can develop in the legs, evacuate themselves out, and settle somewhere else in the body. If they settle in the lungs, that can cause respiratory or cardiac failure. That's something that's called a deep vein thrombosis. Those thromboses and CVI are also very highly linked because there's they commonly form in the leg, and they commonly form in the leg when the blood is pooling. There's another linkage there's another common linkage between deep vein thrombosis or DVT and CVI. If those varicose veins become distended over a long period of time, they can become weakened by that pressure because they're just not meant to accommodate that level of blood flow. That's sort of reserved for the veins with the venous insufficiency on the middle in most times. And so those varicose veins can become weakened over time and eventually burst or hemorrhage. That's called a varicose vein hemorrhage. Risk factors for CVI include a family history of CVI or deep vein thrombosis. I did mention that deep vein thromboses and CVI are linked. It's another age-dependent illness. So in this case, patients over the age of 30 are more likely to develop CVI. Vocations that include long periods of sitting or standing. Women are more prone to get CVI, especially those who have undergone multiple pregnancies. Prior blood clots in the superficial or the deep veins is another sign that those blood clots are forming because the blood is pooling there. Obesity or a sedentary lifestyle, high blood pressure, or limited physical activity are all risk factors for CVI. And then varicose veins and CVI, sort of two sides of the same coin here. So varicose veins in the presence of an ulcer, in the presence of inflammation or infection, in the presence of pain, swelling, or edema, in the presence of phlebitis or thrombophlebitis, and in the presence of embolism, are all risk factors or red flags for chronic venous insufficiency. Okay, at this point, we're going to move to the next stage of the webinar where we discuss the the Vascular Assessment Protocol, how to do it, and what it's for. So as you probably gathered from the extensive list of risk factors we've just gone over, there's a lot of risk factors that are overlapping between patients for PAD and patients with CVI. You know, and that just has to do with the linked nature of artery disease, especially in the legs, and just naturally overlapping risk factors. PAD and CVI are both more likely to develop in patients that have histories of smoking, obesity, diabetes, high cholesterol, hypertension, things of that nature. Now, as most of you are aware, the reimbursement for the CVI test that was reimbursable in 2016, in 2017, that has been removed. So 93965 is no longer a reimbursable code with the PADnet device. There's not a replacement code at this time, although we are working very hard to get a code reinserted for this test in 2018. One of the sort of results of that code change is we're now, rather than recommending one protocol to where you identify symptomatic patients and test them, we're now creating a new protocol to help you identify more patients for PAD. The goal being is that you want to identify patients with PAD earlier. You also want to identify patients with CVI earlier, given the fact that this is no longer a reimbursable code, and you want to increase the overall return on investment for the PADnet device. So the first protocol is for symptomatic patients. This is probably pretty familiar to most of you already, because it's probably how most of you are identifying patients right now. You're going to identify a symptomatic patient. You might use one of our questionnaires. We have a series of questionnaires that ask simple yes or no questions. Checking yes on any of those questions qualifies them for a PADnet study. So you might have a patient, some offices that successfully use the questionnaire, most of them just hand this questionnaire out to all patients over the age of 50, and they'll say, yes, I have foot or toe pain that disturbs my sleep, or yes, I have cold hands and feet commonly. You know, again, there's a number of those questions. Alternatively, they may have a visible symptom of PAD. For example, they may have that pale or bluish skin in the extremities. They may lack a pedal or a foot pulse. They may have unusual hair growth patterns, something along those lines. During your interview with the patient, something may come up with a symptom that may be erectile dysfunction. That may be, again, foot or toe pain while walking. Anything along those lines. Lastly, you may find a patient based on a review of the CPT codes in their history. So, excuse me, the ICD-10 codes in their history. So, for example, you might go in and you might create a list of all patients who have previously complained of claudication. Possibly, you're going to look at all patients who are diabetic and have cardiovascular complications. That's another indication for the PADnet study. So whatever method you're using, you're going to find a patient that complains of a symptom of PAD. You're going to schedule them for the PADnet. You're going to schedule them for the PADnet test. They're going to come in, and then they're going to come in 2 weeks later, and you'll discuss the results. If assuming that they initially came in with another complaint, you can schedule an office visit for that code. And then when they come in for the arterial test, you'll bill for 93923, and then bill for another code as they come in for the follow-up. So that comes out to a total reimbursement of about $300 per symptomatic patient. Now, obviously, we're going to talk about reimbursement here a lot over the next few slides. So I want to take a second and highlight that obviously we can't guarantee your reimbursement. The CPT codes that I'm citing are examples of appropriate E&M codes, but everybody's a cardiovascular professional working in Illinois is going to have different requirements and different leeway about how to bill for E&M codes and how to do this than, let's say, a podiatry office in New York. The requirements and the insurance are different. I also want to mention that the numbers that I'm assigning, the value that I'm assigning, is based on the national average for Medicare reimbursement. As you're looking at different insurance companies or different LCDs, that reimbursement may go up or down. Okay, so you've identified symptomatic patients using one of the four pathways that I identified on the last slide. You're testing all of those patients as they come in. That's great. However, about 2/3 of patients, and I've seen, you know, we're currently looking at this data. I've seen other reports that say up to 75% of patients are asymptomatic. Now, what does that mean? That might mean that they don't have any symptoms at all. That's actually not uncommon for patients suffering from PAD to literally simply have no symptoms of the disease. It may also mean, you know, probably the most common or the classic symptom of PAD is claudication, which is to say pain while walking. And if you ask an 85-year-old if their legs hurt, they're probably going to say yes. And so they may be experiencing claudication, but instead misattributing that to something else. Another condition they have, like arthritis, for example, is a very common one. So, and again, we're looking at a lot of patients here in a lot of high-risk categories, over 50 with a history of smoking, over 50 with a history of diabetes, or over 70. So how are we going to identify those patients who don't have a symptom? That's what identifying these 2/3 of patients, that's what the new screening protocol is for. So again, we're looking at risk, we're looking at a large number of risk factors for PAD. We've gone over all of these lists. You know, we've gone over both the PAD and the CVI list, so I won't bore you by repeating this entire list again. But as you can see, there's a lot of things on this list which, you know, are going to cover a wide variety of patients. So since we're looking at all of these patients now and not just the ones that have a symptom, an indication for the PADnet device, we're casting all in all a much larger net and finding a lot more patients. Now, the actual vascular assessment itself is very, very quick. We're going to be doing a full venous study. I'll show you what that looks like here in a minute, but it just takes about 5 minutes to perform, probably less. At that point, you're going to lay them down on the table. And you're going to perform one segment of the arterial study. And then the doctor, the care provider, will come in and interpret the results. They'll discuss whether or not the study results were normal or abnormal, and then they'll discuss recommendations for improvement for the future. Oftentimes that might be changes in diet or exercise or smoking cessation, but if it's appropriate, it can also include whether or not they're due for a full arterial study. So this is in comparison to the protocol for the symptomatic patients. So just as a reminder, for the symptomatic patients, the patient comes in for another complaint. You notice that they have an indication for the study. You schedule them for the study. They come back in, you perform that study, and then they come back in 2 weeks later and you discuss the results. So you're getting one office visit for the initial complaint, one CPT code for the reimbursable PADnet study, and one reimbursement for the office visit as they come back in. So in this case, what you're going to do is the protocol is going to look very similar, but with an additional step. The patient is going to come in for another complaint. You're going to notice that they have a risk factor, but not an indication. And then you're going to discuss your concerns about the risk factor and schedule them for the vascular assessment protocol. Oftentimes that additional, that discussion of your concerns about the risk factor and your scheduling of the vascular assessment protocol will allow you to elevate your initial E&M code and charge the insurance for more for that initial office visit. As it is, they're going to come in for the second, they're going to come in for the vascular assessment protocol. You're going to perform the venous test, the arterial test, and then discuss the results. You'll bill for an office code for that visit. If the results are abnormal, you're done. excuse me, if the results are normal, you're done. You just schedule them for an office visit. In 12 months, you can perform the vascular assessment protocol again. Or if they're abnormal, then you can schedule them for the full PADnet study. Just like with the symptomatic patient protocol, if the patient has a PADnet test, you schedule them for the PADnet test and then schedule them a follow-up discussion to discuss the results. At this point, I want to show you what that's going to look like in the what the vascular assessment is going to look like inside the PADnet software. So give me just a moment while I move our view over to the PADnet software here. And then I misspell our password. There we go. Okay, so we're going to click, we have our patient. They came in for a vascular assessment. You click Perform New Venous Test. I've been testing our presidents over our, while I've been showing people tests last week, so I'm going to continue that, and we're going to test my favorite president, James Garfield, who was present in, I think, 1884. So we're going to say 1884. The only 3 fields that you need, this is a screening protocol and not a test. So generally speaking, there are a lot of required, there's a lot of required information here that we're just going to bypass. So we're going to list this as a screening. We're going to enter the patient's first and last name with the patient's ID number, which is going to allow us to skip the insurance, the history, the physical, the indications, and then go on to the venous test. Just a second while I put us here in demo mode. Of course, I don't have an actual patient here, so we're going to have to do the demo study today. We're going to click Perform. We're going to click Start. We're going to wait for the test. It takes 40 seconds or so, probably, for each leg. In a second here, the system will instruct the technician to have the patient begin dorsiflexions. You'll see it in yellow. There it is. Please have the patient perform 5 to 10 dorsiflexions. The patient will perform the exercise 5 to 10 times. I don't think that this is this demo mode study isn't a really great example of what an actual venous test looks like, unfortunately. But it, broadly speaking, has the same features. So you'll be able to see on the left-hand side the big dorsiflexions, those big up and down motion as blood is being evacuated out of the leg. And then you're going to calculate the refill time. We have a refill time on this leg of about 24 seconds. So determining whether a venous test or not is abnormal or not is very, very simple, because it just depends on the refill time that I calculated, or in your case, the technician calculated. This patient has a refill time of 24 seconds. A normal refill time is greater than 20 seconds. An abnormal refill time is 20 seconds or lower. So you can tell from this, just from this number here, it's very cut and dry whether or not the patient is abnormal or not. So if you were performing the full vascular assessment, you'd save this, you'd go into the next leg, and you'd perform the same leg over again. Again, it's very short, just 30 seconds or so. But in this case, because because we're just doing a demo study and I don't want to make you just watch that leg refill, that fake leg refill again, we're going to go back and we're going to do the other portion of the vascular assessment. So in this case, we're going to assume that we're done with the test. We're going to click Home. You're going to click Perform New PAD Test. And we're going to test Mr. Garfield again here. So what you do to do that is you just click, you just enter the patient's first and last name, you click Find, and it brings the patient up no problem. So if I had entered this patient's information already during the last test, the screening protocol, I wouldn't need to enter it again. I can just enter first and last name, Find, it brings all the patient's information up. Just like with the venous test, we don't need to include information on the insurance, the history, or the indications. We're just going to go straight to performing the PAD test. So you click Perform, and then we click the right ankle, and we're just going to take a waveform here. So this portion of the test, it's again very short, just a minute or two. We click Stop. Then we're going to click Save and then Next, and we're going to take the waveform on the left ankle as well. We'll talk about, and at this point, you're done with the actual testing portion of the vascular assessment. So at this point, the interpreting doctor can come in and look at the results for the PAD and the CVI study and determine whether either of those is abnormal. Give me just a second here. I'm going to move us back to the PowerPoint presentation so I can talk about how we determine whether or not those waveforms are normal or abnormal. So this is an example of one waveform. You can see the similarities between this shape and the shape that was, and those waveforms that were going across the screen. You'll notice a couple of features of this that I wanted to highlight. There is a steep upslope, so we're not looking at anything rounded. That should go up very quickly. That should have a very steep upslope. It should have a narrow peak. It should have a narrow down. It should have a strong downstroke or a steep downstroke as well. And then there should be that sort of bump out on the way down. That's called the dicrotic notch. The dicrotic notch is very important because it's pretty much the first thing that gets lost in a patient that's suffering from mild PAD. So as you look at if you look at patients with very advanced PAD, there's almost not a waveform at all. It looks very diminished, very dampened, and it's obvious to anybody with experience with waveforms that that's not a normal or a healthy waveform. However, for patients with mild PAD, what you're going to see is these very narrow, mountainous, almost triangular peaks that look kind of normal, but they're missing that dicrotic notch. So I want everyone to keep their eyes out, when they're evaluating that. I want everyone to keep an eye peeled for differentiating mild PAD from mild PAD from healthy patients, because they're missing that dicrotic notch. So here are some sample waveforms. The one at the top is again for mild PAD, and you'll see these narrow mountainous triangular peaks here that are just missing that sort of extra curve on the end. As the disease worsens, moderate PAD, the peaks start to become less pronounced, and everything starts to become rounder and sort of hillier as opposed to mountainous, if that makes sense. And then again, as the occlusion worsens, we stop getting things just become more and more dampened, rounder and rounder, until eventually in critical patients you're really not able to get much of a waveform at all. So you can tell if you see a waveform like one of these three in comparison to that big beautiful rounded waveform that we saw in the last slide. This is a normal PVR, these are abnormal PVRs. Now you have your screening protocol. It took you about 5 minutes to take the data. Do you have an indication for a PADnet study? If you have an abnormal waveform, if your waveforms on either of the ankles for the patient look like this one, then you're indicated. The ICD-10 code in that case is I-77.1, stricture of the artery, and this is an ICD-10 code that works as an indication in all states. If your results are abnormal in the CVI study, the best result is I-73.9, which is PVD, or peripheral vascular disease unspecified. And that is an indication in all but 3 states. That's Alabama, Georgia, and Tennessee, who use a different who use their own LCD. If the CVI result comes back abnormal in one of those states and the patient is diabetic, then you have an indication. And that's E10, E11, or E13.59. which is diabetes with vascular complications, and the code varies a little bit depending on whether or not, on what variety, what form of diabetes the patient has. And so the abnormal waveform code will work in all states. The abnormal CVI code works in all states except Alabama, Georgia, and Tennessee. And in those patients, an abnormal waveform is still an abnormal CVI study is indicative for a PAD study if the patient has diabetes, but it isn't if the patient is not. So at this point, you've seen me doing, you've seen me billing, quote unquote, billing for a lot of these office visits using something called E&M codes. So some offices use E&M codes all the time, and they're going to know way more than I do about it. Some offices don't bill for E&M codes. So I wanted to take a second to highlight, to go over what an E&M code is and how we recommend it be used in terms of the Peripheral Assessment Protocol. So there are two ways, E&M codes, broadly speaking, are a way that offices can bill for time, for patient visits without billing for a specific CPT code for a procedure. So for example, at this point, 93965 is no longer a CPT code that's reimbursable. So we're recommending that we use these evaluation and management codes instead. There are two kinds of evaluation and management codes. The first one bills on complexity, and it has to do with the number of different conditions, the number of different specific medical discussions you have with the patient, and it rewards you for examining, discussing, talking to sicker patients with more conditions. They're complicated to bill for, and so our recommendation are that you use time-based coding. Now, the challenge with time-based coding is that just like all insurance protocols, if it isn't written down, it didn't happen. And so you need to write down everything to do with the vascular assessment protocol in order that you can submit that to the insurance without it being a hassle. So I want to highlight this quote about billing for time-based E&M codes. When counseling and coordination of care dominates the physician-patient or family encounter, then time may be considered the key or controlling factor to qualify for a particular level of E&M services. So I want to highlight that when we're talking about coordination of care and the time that's spent, what we're talking about is the doctor or the care provider's time. So we're going to be spending some period of time performing a vascular assessment on the patient. That needs to take up less than 50% of the time that's being spent. So if we're billing for 20-minute E&M code, the care provider or the doctor needs to spend at least 10 minutes and 1 second with the patient. Just a couple of highlights, a couple of notes here. Only face-to-face time between the doctor and the patient counts. Telemedicine or anything along those lines isn't going to work for these codes. And you need to document the actual time that's spent with the patient, and you need to include notes that reflect the counseling or coordination of care activities, and that you need to identify all the major areas of discussion. So to make all of these easier and to make that, to make this as easy as possible for you, we have made a document that will allow you to easily, keep track of all of the time that's spent, so you can bill for those E&M codes. This is the top half of the sheet. There are, you circle one of the patient's symptoms. That's the reason that they're getting the this vascular assessment protocol. You'll be familiar with all of those different symptoms, but if you need to write a new one, Raynaud syndrome, anything along those lines, there's obviously space to do that as well. You're then going to perform the venous assessment. You're going to circle whether or not that refill time was more or less than 20 seconds. Again, that 20 seconds is the dividing line between a healthy, normal refill time or not having or having CVI and not having CVI, essentially. And then you're going to calculate the amount of time spent administering the venous assessment, and then down below, the doctor is going to spend a time reviewing the venous assessment with the patient. Something like, Mrs. Smith, I have the results from the test that you just took. I wanted to talk to you about what it means. I can see here that your refill time was 17 seconds. Let's talk about what that means for you, something along those lines. This is the second half of the sheet. The arterial form, the arterial portion is pretty familiar. Should look pretty much the same. You're going to document the amount of time administering the arterial test. You're going to circle the patient's diagnosis. Does the patient have normal or abnormal waveforms in the ankles? And then the interpreting physician is going to mark how much time was spent discussing those results with the patient. Mrs. Smith, now that we're moving on to the arterial test, I can see that you have waveforms and these peaks are nice and big, which is good, but you're lacking these dicrotic knots, which concerns me. Let me talk about that. You'll spend the amount of time reviewing the arterial assessment, circle that as well, and then discuss the care orders with the patient, discuss the recommendations to the patient. And you can see a number of very common recommendations down here. Diabetic patients that have a positive or an abnormal CVI study do qualify for things like compression stockings or diabetic shoes, because they now qualify for things like diabetes with complications. So diabetic shoe recommendations are very, very common if the patient has an abnormal CVI study. At the end, you just need to mark what percentage of time was spent counseling or coordinating the care. Again, it needs to be greater than 50% to qualify. And then at that point, you're done. I just wanted to give you a brief glimpse at the time-based E&M office visit codes, the ones that I have been using during this test. There are two different levels of codes. The first one is for new patients that you've never seen before. The second one is for established patients, patients that you have seen before. As you can see, they're not exactly one-to-one, so 99211 is a 5-minute code, whereas 99201 is a 10-minute code. So you're going to want to keep an eye on, you want to remember what duration of time you're looking at, depending on whether the patient's a new or an established patient. One other thing that I wanted to mention here is, again, we're often recommending that you schedule these for patients when they come in for with another complaint. So for our symptomatic patient protocol or for our asymptomatic patient protocol, at the beginning, the first step is the patient is coming in with another complaint, and then you're looking at either their indications or the risk factors, and then you're going to say, Mr. Smith, I'm glad that we were able to help you out with what you came in for today, but I want to notice that since you've complained of claudication, or since you are over 50 with a history of smoking, we want you to come back in for this vascular assessment protocol or the full arterial test. Spending that time discussing that with the patient is often going to help you elevate your E&M codes to the next level to achieve additional reimbursement that way. So we're now casting, if you cast your mind back to the estimated reimbursement based on asymptomatic patients, we're looking at an average reimbursement of a little less than $300 per symptomatic patient. At this point, we're going, again, because we're casting a wider net, we're looking at more patients that have risk factors. Now, if you take 10 patients with a risk factor, we're estimating that 3 or 4 patients are going to test positive for PAD. So you're going to have 10 patients that come to the screening protocol. They're going to come in for something else. You're going to say, Mr. Smith, I noticed that because of your risk factors, you're likely to have PAD or CVI. We'd like you to come in for this vascular assessment. That'll help you elevate that E&M code. They'll come in for the vascular assessment. You'll bill for that E&M code, and then they'll come up negative. We're expecting that 7 of those patients are going to come up negative, at which point you'll reschedule them for the vascular assessment for 12 months. 3 of the patients, though, we are expecting are going to have PAD. So they're going to come in with another complaint. You're going to say, Mr. Jones, we noticed that you have, because of your history of smoking, you're at risk for PAD and CVI. We'd like to schedule you for the vascular assessment. They come in for the vascular assessment. You bill for that vascular assessment code. These 3 patients are coming up positive or abnormal for PAD, so you schedule them for the full arterial test as well and bill for that code, and then you come back to discuss the study results as well. Now, for the normal patients, you're seeing 7 of them, you're billing for 2 office visits, and you're getting a reimbursement of about $216 a patient. For the 3 patients who have the arterial disease, you're billing for 2 office visits, the initial visit and the assessment protocol visit. You're billing them for the full PAD study, and then you're billing for a 3rd office visit to discuss the study results. That comes back with a reimbursement of about $409 a patient. So as you can see here, when these 10 patients that we've tested, we've detected disease in 3 patients who would otherwise not have been included in your protocol, and so we're identifying patients with the disease a lot earlier. Now, we can tell you that from our numbers that people, generally speaking, do not test enough patients for PAD, which means that their abnormal and normal results are often very, very high. You're only testing patients that have symptoms, which means you're only testing the sickest patients. I've seen offices that have 75 or 80% abnormality rates just because of the patients that they're testing. If you go and look at your data and you're seeing abnormality rates of greater than 50% or so, that's an indication that you're just not testing enough patients for PAD. You're testing them too late in the process, which is why your abnormality rate is so much higher than the national average. So one of the things that we're really trying to do here with this vascular assessment protocol is identify patients earlier to protect them from amputation. Because this is a systemic process, there's a lot of overlap between patients with PAD who are also suffering from other things like cardiovascular disease or cerebrovascular disease. At this time, we are nearing the end of the webinar, so I do want to encourage everybody anybody who has questions that hasn't had the opportunity yet, to click the raise your hand button so I can address those here at the end. But I did want to take a couple of minutes to highlight some special offers going on at Biomedix right now that you might want to take advantage of. The first one is technologist certification through the American College of Foot and Ankle Orthopedics Medicine, or ACFAOM. Most states and most insurance companies have a requirement that technologists performing these studies are certified through a nationally recognized body. Through Biomedix, you can be certified through a program with our partners at ACFAOM. This is a 1-year certification at no cost to you. Training for the certification can be purchased if you would like, but more commonly involves the attendance of the webinars like the one that you're at today, or by reviewing our webinars on our YouTube channel. After you've been trained, give us a call and we'll send you an email with a test the technologist will need to take and pass that exam. After they pass the exam, they're considered provisionally certified under the doctor's supervision. During that probationary period, they'll need to take and complete 10 studies on 10 real patients. We'll review those for quality. This is a quality control program. And then we'll issue you that 12-month certification. That certification lasts for 12 months, and you'll need to go through the protocol again next year. However, you can skip that process by performing at least 1 study a month. As long as you perform at least 1 study a month in the interim, then we'll reissue you the 12-month certification, recertification free of charge. Another service that I wanted to highlight is our chart review service. This is probably the single easiest way to identify PADnet patients. So whenever I have a conversation with an office manager or someone and they say, we want to use this device more often, this is what I recommend. At your invitation, we can remote in. to your electronic medical records, and we'll look at the ICD-10 codes in your patient's history. We'll give you two lists. The first list will be indicated patients, patients who've already had a study, who already have an indication in their history that they need a PADnet study. These will be patients with things like a history of claudication, a history of gangrene or ulcers on their legs and feet, patients who suffer from foot or toe pain, things of that nature, which means that they should be tested for PAD as soon as possible. The second list will be patients with risk factors. These are the patients that we recommend to go through the vascular assessment protocol, or patients be given questionnaires so you can identify them for the full PADnet study that way. This list is a free service. It generally takes us a couple, after we remote in to your EMR, it generally takes us a couple of hours to create those reports. And then if we find at least 100 patients, we'll give you a free month of service at the same level that you're already operating under, just as a show of support for you and your medical staff. The last thing that I wanted to highlight is called the Security Vault. This is an upgrade that's available for both models of the device. We've made some upgrades to the technology, to our software recently, and we wanted to make sure that those upgrades were available not just to our new clients, but to our existing clients as well. So if you're interested in the latest upgrades, it allows for enhanced security. It allows for faster testing. It gives you a free upgrade to ICD-10 codes. I know many people using the device are still using the ICD-9 codes, simply because that's what the system defaults to without an upgrade. Purchasing the Security Vault does allow you to, does give you that free automatic upgrade to ICD-10 codes as well. For doctors that interpret their own studies or would prefer to interpret their own studies, purchasing a Security Vault also gives you free access to the read license as well, so you can do that. Now, the last thing that I wanted to mention is that this Security Vault also makes your device agnostic. So generally speaking, most PADnet studies are performed with a laptop, a PADnet laptop that you guys purchased from us. Purchasing the Security Vault means that you no longer need to use that laptop. You certainly can, but you can perform PADnet studies from any device that has access to wireless. So using the Security Vault, you could perform a test on your phone, you could perform a test on a tablet, or you could simply purchase your own laptop and use that rather than using one of the laptops that you guys have purchased from us. So if you're interested, please give us a call at 888-889-8997 or shoot us an email to support@biomedix.com, and we'd be happy to help. At this point, I do want to open it up for questions. So if anybody had any questions before the end of the webinar, please feel free to ask. Okay, at this time, there don't seem to be any questions, so I'm going to let you all go. For those of you who are attending every webinar this week, those of you who are going through the full academy, I look forward to seeing you tomorrow when we discuss the venous test, how to perform it, a little more in depth on the nature of chronic venous insufficiency, yeah, I look forward to seeing everyone there, and I hope you have a nice rest of your day. Thanks for attending today.